Well, welcome everyone to our web event today. This is one of our Webinar Wednesday events, so we're very happy that you all could join us on this Wednesday. And what we're going to be talking about today is health impact of the physical and social environment. So, you know, as we know, health is not just dependent on genetics or potential ability to treat with medication and things like that. It's very much related to the environment people are in, their social connections. And so we're going to talk a little bit more today in depth about how that environment can really affect health. And so this really relates to our Health Intersections Learning Community Group topic. This webinar today is sponsored by our Learning Communities Resource Center out of the National Community Action Partnership. And I'm Courtney Kohler. I'm a Senior Associate with the Community Action Partnership, work on the Learning Communities Resource Center, as well as overall our training and technical assistance team. So I'm going to give you a little bit of introductory information today. We always like to start out with our promise of community action, and then I'll be introducing our subject matter expert for the webinar. So as we start out with our promise of community action, you all can join me at your desk. The community action changes people's lives, embodies the spirit of hope, improves communities, and makes America a better place to live. We care about the entire community, and we are dedicated to helping people help themselves and each other. So really what the learning community is, the Community Action Partnership, is we want to build capacity to increase impact. And so we work with local community action agencies throughout the nation to really look at those community action outcomes, look at those effective, promising, and innovative practice models that work to alleviate the causes and conditions of poverty. So we're all about really building that capacity of the local agencies, of the state associations, as well as the state CSBG offices for community action to be able to fight poverty most effectively. So our LCRC team is here on the screen. You can see some of our photos so that you can kind of tie those names you see in emails and such to faces. And so we have our Director of Practice Transformation, Tiffany Marley, who leads Learning Communities Resource Center. We also have Jarl Crocker on the team. He is our Director of Training and Technical Assistance. Hyacinth McKinley and Liza Porras are both program associates. Myself, Courtney Kohler. And then we also have Jeannie Chapman, who is a consultant on our team as well. And then with us today, we have our subject matter expert, Dr. Dana Long, and she is the Director of Health Equity, Science, and Clinical Transformation at the UCSF Binoff Children's Hospital in Oakland. And so she serves as our subject matter expert for our Health Intersections Learning Community, and she's going to be presenting our information to us today. All right, so Dana, I'm going to go ahead and turn it over to you and pass over the presenter ball.
Can you hear me, Courtney?
Yes, you're coming through good now.
Okay, great. Good morning, everyone. It feels like such a luxury to actually have a small group. There are 39 of you on the call. And I'm hoping today to talk about health outcomes that are associated with determinants of health and adverse childhood experiences. As much as possible, I would love to make this interactive, and so I'm going to talk about some of the science and the research about how determinants of health and early childhood adversity actually disrupt our biologic systems. And so please, you guys, enter questions and chat with me as we go so that we all can get the most out of this webinar. And I'm so glad that you guys all joined us. So I have no conflicts of interest to discuss. And the learning objectives for today are really three. The first is to describe how determinants of health and ACEs are grounded in science and how they impact outcomes. I want to focus particularly on early brain development and asthma, which are two of the diseases that we know are most prevalent in children that are experiencing trauma. And then I want to talk briefly about the broader policy and systems level change that we currently are undergoing around how we're doing screening and referral and case management for ACEs and determinants of health. So all of you guys on the phone know that at this point we have a public health crisis and that there is an invisible threat to the lifetime health of our population. This threat causes a dramatic increase in the risk for 7 out of 10 of the leading causes of death in the United States. It affects brain development, the immune system, our hormonal systems, and even the way that our DNA is read and transcribed. It triples the lifetime risk of heart disease and lung cancer, and it can reduce our life expectancy for up to 20 years. That threat is what we know to be ACEs, and traditionally there are 3 types, 3 domains of ACEs that comprise 10 questions on a questionnaire that was developed as a joint collaborative effort between the Center for Disease Control and Kaiser Permanente in the 1990s. So those 3 traditional categories are about abuse, neglect, and household dysfunction. What we know is that if you experience 4 or more traumatic events before the age of 18, there are consequences across the life spectrum. And those consequences, as you enter adulthood, lead to physical health as well as social and emotional health issues. So that you're more likely to have cancer, diabetes, heart disease, we could put obesity on here, and you're also more likely to engage in at-risk behavior, whether it's substance abuse, so alcoholism or other substances, multiple sexual partners, as well as you're 12 times more likely to attempt suicide. If you have 4 or more ACEs, you're more likely on average to have a reduction in your life expectancy by approximately 20 years. We've known this data. This data was initially published almost 30 years ago in the 1990s. At this point, we need to shout off the rooftops that we need to do everything that's in our power in order to help protect families and children, since we know that there are consequences for social and emotional factors. If we look at national prevalence data across the United States, surveys have demonstrated that nearly 2 out of 3 adults have at least 1 ACE. That's 64% of our population has at least 1 ACE, and 12% of the U.S. population on average has 4 or more ACEs. Nearly half of all children have at least 1 ACE, and you can see in this graphic that about half the population has no ACEs, and then almost half the population has at least 1. When we look at the odds ratio, so this is the odds of developing a leading cause of death and its association with ACEs, we can see that whether it's heart disease, cancer, respiratory infections, diabetes, the odds of having a chronic illness that leads to mortality is much higher if you have ACEs, particularly if you have 4 or more early adverse childhood experiences. If we look across racial groups, we can see that on average, about 46% of all children have at least 1 ACE. When we then stratify that out based upon the ethnicity of children, we can see that by far African American on average have more ACEs than any other ethnicity, followed by Latinos, followed by whites, then Asian Americans. If we stratify ACEs by socio-economic impact, we can see that the lower your socioeconomic status, the higher your ACEs, such that if you make less than $15,000 a year, you're more likely to have ACEs than if you actually make more money. So that 1/4 of low-income adults have at least 4 or more ACEs. We also have discovered that ACEs accumulate over time. So most children accumulate ACEs over the course of their life. On average, our 0 to 6-year-olds have approximately 2 ACEs. And by the time that they're between the age of 12 to 18, that has extended to almost 5 ACEs. This slide really helps to make the point that we actually need to intervene early before kids can accumulate more ACEs and then have the health outcomes that are associated with those high scores. So if we wanted to look at our pediatric population, we pulled the data, and children who experience 4 or more ACEs are 10 to 12 times more likely to use substances or attempt suicide. They're more likely to have the leading causes of death in the United States. They're more likely to have pulmonary diseases like asthma. They're 4.5 times more likely to have depression. And they're 32 times more likely to have learning and behavioral problems. As we start to think about school readiness and how we can actually get all of our kids ready to learn with the cognitive and social emotional skills that they need in order to enter kindergarten, if we don't address ACEs, we actually cannot address school readiness. This problem is profound, and it needs to start from the beginning. So a group of us got together, including Nadine Burke-Harris from the Center for Youth Wellness, who is now our new Surgeon General in the state of California, and we all started to think, well, how can we start to develop a prospective pediatric screening tool for early childhood adversity? We started to think, what would that tool look like? What's the feasibility of doing universal screening? About how we can connect it to biomarkers and clinical diagnoses, as well as how can we actually intervene, one for primary intervention, so before ACEs start, but also for secondary intervention, once a child has ACEs, but they're not currently symptomatic. So we started to look at the traditional ACEs questionnaire, which includes 3 domains and 10 questions. We actually pulled from other ACEs screening tools that were used across the world by various health departments and the World Health Organization. We pulled all those tools apart and we stratified them by category. And then we wanted to think about social determinants of health as well. And is there a link between unmet basic needs like food and housing and biologic dysregulation? What's the evidence of long-term biologic disruption secondary to unmet basic needs? We piloted a screening tool in an iterative rapid cycle fashion within our clinic population, and we engaged multiple stakeholders. These stakeholders included our providers, our staff, as well as our patients themselves to develop a tool, and I will share that tool with you. So the tool was published just this December in a peer-reviewed journal. I give you the citation if you want to look at it, and Courtney can actually send the article out to everyone. And basically, the instrument that we developed, it was validated with face validation for tonality and clarity in both Spanish and English, and we currently are doing the statistical validation for this tool. We discovered that it had high acceptability, and there was some discomfort with the tool, particularly around issues of sexual abuse, separation from caregiver, and community violence. That discomfort seems supernatural and normal, knowing that those are really hard things to discuss. And altogether, we expanded the initial 10 ACEs questions to 17 that are included in this survey. So of the initial domains, those 3 domains, I do want to comment that we expanded the question on emotional abuse to include both emotional neglect and physical neglect. We also expanded the initial question on incarceration to make it broader so that it included other forms of separation from caregivers, including the placement in foster care, deportation, or immigration. We added questions about death of a caregiver. We also broadened the initial question about divorce to really assess family cohesion, knowing that many families in our community are not married and are co-parenting. Within the domain of household dysfunction, we added a question about serious physical illness or disability within the household. And then, as I said before, we wanted to look at these determinants of health and the mechanisms for biologic disruption secondary to the most evidence-based questions around food insecurity, housing instability, discrimination and bullying, and then violence outside of the homes and communities. So when we initially piloted the questionnaires within our clinic, we asked the adult caregivers to take the original 10 ACEs questions. And what we found was really horrifying and starkly different from the data that I presented at the beginning of this presentation. So I had mentioned to you that national prevalence data is that 64% of our national population has at least one ACE. Within our urban low-income communities, we found that 92.2% of our caregivers endorsed at least one or more of the traditional 10 ACEs. The clinic that I work at, it's a fairly qualified health center, which means that upwards of 90% of our families are families of color, and upwards of 90% of our families are also on Medi-Cal, which means that they live at or below the poverty level. We also found that nearly half of our families endorsed 4 or more ACEs. And you can look at this graph and see what the percentages of those endorsements were. There's a huge percentage of our families that are being affected by substance abuse, verbal abuse. 50% of our caregivers said that they had been separated from their caregiver. Endorsement rates for sexual abuse were super high, almost 40%. Domestic violence was happening in 1 out of 4 of our families. Incarceration, 1 in 4 of our families. These percentages are really high. We wanted to compare our pilot data, so we call our pilot data FIT, which stands for the feasibility of implementing tools, to the initial original ACEs data that was published by Dr. Anda and Dr. Vitelli. And you can see that the vast majority of our percentages of endorsed adversities are much higher, except for 1. And that one difference is the mental illness category. And so we really took a deep dive into why that is, and so much of it is the stigma associated around mental illness. And so we did some rapid cycle testing with the mental illness question, and what we ended up doing is we ended up giving examples, such as, does a caregiver suffer from mental illness, such as depression, so that it became much more of a concrete topic for families. Using our new prospective pediatric ACEs screening tool, we call it the PEARLS tool. So PEARLS stands for the Pediatric Early Adversity and Related Life Events tool. We found that 82% of our caregivers endorsed that their young children, so these are children prior to the age of 12. The median age of our patient population was about 5.8. What we found is that 82% of our caregivers endorsed 1 or more from this list, and over half of our very young children had at least 4 or more ACEs. I had mentioned that the initial ACEs study had 3 domains, and we added a domain for determinants of health. And you can see how those additional questions panned out here. And so we added a question for community violence, and you could see that 60% of our families endorsed that this is a substantial concern. We added a question about food insecurity. We added the question about housing insecurity. And it's no surprise to me, but when we did the data analysis for how our families were answering the discrimination question, we see that 1 in 5 of our very young children are also endorsing being discriminated against. So how does this relate to our biologic systems? And this is the connection that a lot of us that are doing research are really hooked on answering, is how are these what are considered social factors actually related to our biology, and how do disruptions in normal biologic processes then lead to poor health? So what we know is that stress affects us. It affects our minds, it affects our bodies. And there are 3 types of stress. The first type of stress is positive stress. This is brief stress that might cause elevations in heart rate, mild elevations in stress hormones, but otherwise positive stress is pretty benign. An example of positive stress is giving a webinar. It might be that you have to take a test, right? It is mild stress that's super brief. Tolerable stress is more serious stress. Tolerable stress is stress that's secondary to the fact that you're grieving the loss of a grandparent. But it's temporary and it's buffered by safe, stable, supportive relationships with adults in the household. And then there's toxic stress. And toxic stress is stress that is prolonged. It causes activation of our stress response system, and it's in absence of a safe, stable relationship with a caregiver. We know that these stressors, such as trauma, such as living in neighborhoods where there's a ton of violence, such as living in neighborhoods where there's food insecurity or there's not enough housing, we know that these stressors actually are now impacting the type of stress that we have, how the stress is perceived, the ability to cope with it, and then there's some biologic variation depending upon our own immune responses. And those immune responses are our neuroendocrine system, it's our immune system, it's our genetics, and it's the way that our genes and our environment interact with one another. It's also impacted by the type of bacteria and viruses that are in our environment and that we carry on our bodies. So let's talk about this a little bit more. Let's talk about the biologic impact of early childhood adversity. And so when a child has adverse experiences, there are protective factors, right? Safe, stable, buffering relationships with caregivers. We also know that we have predisposed vulnerabilities that are part of how we respond to stress. When stress becomes toxic, it causes prolonged activation of our neuroendocrine system and our immune system. That then leads to clinical implications within our immune systems, our metabolic systems, our reproductive systems, our neurologic symptoms, our mental health, as well as our ability to fight off infections and the health of our hearts. We also know that the biologic impacts can disrupt the way that our DNA is read and transcribed, and I'm going to go into that more in a second. So our experience has a profound impact on our biology, particularly in early childhood. So we have our central neurologic responses in the structures of our brain, and then we have our peripheral responses. And so the example that my colleague, Dr. Nadine Burke-Harris, always likes to give is, let's say that you're walking in the woods and you're walking along and there's a beautiful trail. All of a sudden, there's a bear, and that bear is hungry, and he comes out wanting to attack you. What actually happens then is that our structures in our brain become activated. And so we have activation of something that's called our amygdala. And our amygdala is our rage center, right? It responds to fear, it responds to threats, and it is what allows us to either attack that bear or to run away from the bear. We have what's called our prefrontal cortex, and our prefrontal cortex is what enables us to have executive function. We can think of it as our upstairs brain and then our downstairs brain. So our upstairs brain is when we're actually doing really well, we're processing information, we are not impulsive, we are not aggressive, we actually are functioning at the top of our game. Our downstairs brain is when we are impulsive, when we do want to hit, when we do want to strike out. And when you are exposed to toxic stress, you have impaired executive function. We also have a structure in our brain called the hippocampus that allows the two hemispheres of our brain to actually network and to work together. It's what allows us to process vast amounts of information. It helps with learning and it helps with memory. When you have toxic stress, you actually can damage the hippocampus and then you have difficulties with learning and memory. We also have these reward centers within our central structures of our brain. And our reward centers, when they are inhibited, then we don't eat that extra piece of chocolate cake or those 5 other cookies. But when that reward center is stimulated, it leads to increased risk-taking behavior, and that reward center is also activated when we are suffering from toxic stress. So besides the central effects of toxic stress, we also have peripheral effects, and the peripheral effects are our hormonal cascades that actually line up our brain with the other parts of our body. And so one of those peripheral systems is called the sympatoadrenal medullary system, and this is what helps to release our adrenaline, our epinephrine, norepinephrine. It allows us to have that fight or flight response. It increases our awareness, our vigilance, our alertness. It actually causes us to have a little bit of analgesia so we don't feel pain as much. It inhibits hunger. It inhibits digestion. It can also inhibit growth. The other axis that we have is our hypothalamic pituitary axis, and this is what helps to release cortisol. It helps to process sugar and other types of minerals, and problems with that axis can actually lead to things like diabetes or high blood pressure. Both of these axes are overactivated in a toxic stress response. And so then we see these downstream effects, and some of those downstreams affect our end organs, like our adrenal glands, or it affects our ability to grow. It causes changes in the acceleration of puberty. And ultimately, it affects our DNA. So we've recently learned that this type of toxic stress, it leads to what are referred to as epigenetic changes. And epigenetic changes change the way in which DNA is read. And so it doesn't actually affect the base pairs of the DNA, how the DNA is structured, but what is affected is how those structures are read and then how they code for proteins, and then those proteins then lead to disease. An example of an epigenetic change is that you can add in a ball of carbons onto a piece of DNA that then disrupt that DNA as it's read into RNA. The tips of our DNA are called telomeres, and these telomeres are actually linked to aging. There have been studies that, particularly in African American men, there's increased shortening of these telomeres that is an adaptive response to toxic stress. We are in the process of trying to discover what are the biomarkers of stress so that we can actually do risk stratification of patients to identify which patients who are experiencing adversity have biologic alterations that if we can identify early, we can actually prevent disease processes from happening. So we're looking at biomarkers across systems. We currently are involved in a large randomized controlled trial where we're looking at biomarkers for cardiovascular risk factors, such as blood pressure and resting heart rate, and we're collecting serum blood samples in order to see how can we actually identify kids who might end up having issues of hypertension. We're looking at metabolic markers, such as certain types of fats, and what we know is that toxic stress can lead to obesity. And how can we actually identify those kids early on who are at risk for having alterations in lipids that could actually elevate their body mass index and lead to obesity as adults? We're looking at brain function and neuroendocrine biomarkers and brain-derived factors that can let us know if there are alterations in central cognitive functioning. We're looking at biomarkers for the immune system, for inflammation, as well as for biomarkers that are associated with alterations in epigenetic markers, such as telomere length or the way that RNA is read. So there have actually been studies that show that families that have lower social-economic status have higher levels of chronic stress. There's a greater perception of threat. There's higher levels of stress in the body that lead to heightened production of different types of immune markers called cytokines, different types of markers that lead to autoimmune diseases such as eosinophils, which are associated with asthma and allergies. As I said, we also know there's a relationship between race and epigenetic markers. And the real question is that if stress is a process that can wear on, for instance, the telomere length of African American men, how do we actually go ahead and disrupt that process, let alone actually allow the telomeres to re-expand? And I think this is where the holy grail of medicine is right now. When we think about ACEs, there's a lot of people that we all know in our life that have had immense amount of adversity and are completely without any symptoms and lead very healthy lives. Then you have those that have ACEs that are not currently symptomatic but do go on to develop obesity, diabetes, hypertension. And then you have young kids who have ACEs who have symptomatology sort of from the get-go, whether it's disruption from the neuroendocrine system, social, emotional, or cognitive impairment, or they adapt high-risk behaviors. What we need to investigate is how is it that there is such substantial individual variability in the impact of experiences over the life course of individuals with ACEs. And this is why it's important for us actually to start to screen all kids for ACEs, because we need to know which of the kids are at risk for developing health, and that's physical health and mental health outcomes that will lead to poor adult health. And this is sort of where the science is right now. So some of the health impacts of social determinants of health and ACEs over the life course, we can see it starting in babies. We can see that there are growth delays, there's cognitive delays, there's disruption in sleep patterns. As toddlers and preteens, we see that there are higher rates of asthma. In my community, the rate of asthma is about 40%, which is much higher than the national average. We see an increased rate of infections, and some of these are that stress wears your immune system. So kids are getting more URIs, which then lead to, as a trigger for their asthma. There's poor air quality, which then leads to more flares of asthma that then lead to more missed days of school. We know that children that have 4 or more ACEs are 32 times more likely to have learning difficulties and other behavioral concerns. And again, as they grow into adults, there's a higher likelihood of obesity, violence, bullying, smoking, teen pregnancy. We are starting to link up the clinical signs and symptoms early on so that we can recognize that, this young child has both allergies, asthma, ADHD, and a sleep disorder. We should actually talk to them about the stress in their life and the fact that there may be some ACEs there. We're doing this because what we've learned, and we're learning through our study, is that there's a higher odds ratio of this clinical symptomatology as it relates to asthma. And what our data is showing us so far is that there's definitely a higher odds ratio for asthma and obesity in our kids that have 4 or more ACEs. The first 5 years of life are this critical window for brain, language, and emotional development. When a child is born, they actually have 80 million brain cells, and it is how these brain cells are actually connecting with one another that helps to determine who and what we are. So on average, a baby will make about 700 connections per second, every second of their life, which is amazing. And the first 1,000 days of life are the most critical time for what we call neuroplasticity, the ability of the brain to continue to make these synapses and make these connections. For children that are experiencing significant amounts of stress, their brains are still developing and developing in an adaptive fashion. But what we know is that rather than developing executive functioning or cognitive skills, these babies' brains are developing in a way that helps to promote their survival. How are they going to survive, as opposed to how are they actually learning arithmetic? So studies have been linking ACEs with behavioral and learning issues for the last couple of years now. I want to actually show you two different studies that link ACEs to ADHD. And so there was a study that was recently published in the academic Pediatrics in 2017 out of a study from Philadelphia called the Adverse Childhood Experiences in ADHD Diagnosed at 9 Years of Age National Urban Sample. This study actually looked at thousands of kids, and what they showed is that if children had ACEs before the age of 5, there was a higher association with ADHD. There is another study that Nadine Burke-Harris did within her own clinic where she looked at children who were diagnosed with learning and behavior problems and then stratified them by their ACE score. There are always going to be kids that have variations in their in learning. And so there are children that have no ACEs that definitely have learning and behavioral issues. But what we actually see from this graph is that for children that have 4 or more ACEs, they had a higher likelihood of having learning and behavioral issues than children that had no ACEs. And the citation for this article is here, if you guys would like to read it. I also want to talk about this relationship between ACEs and asthma. And what this graph shows are the odds ratio of having asthma and how it varies based upon the degree of early childhood adversity. And so the more ACEs you have, the higher odds ratio you have of developing asthma. This is just another way to show that graph, is that the more ACEs, the higher your odds ratio of having asthma, which is truly an autoimmune disease. This graph looks at the relationship between stress, inflammation, and asthma. And what it's showing is that IgL is a type of inflammatory cell that gets released in your inflammatory cascade. And so there's more likely to have higher levels of these types of white blood cells in your system based upon, in this they looked at, does a family rent or own the home, right? And the more likelihood you have of renting a home versus owning the home, the higher the levels of stress. You can look at the relationship between family savings and their production of these types of inflammatory cells. And so the more savings a family has, the lower the level of inflammation. You can also look at chronic stress in the home. And the higher the amount of chronic stress, the higher the production of these inflammatory cells. There was another fascinating study that came out in 2017. It was about asthma and discrimination. It looked at self-reported racial and ethnic discrimination as a psychosocial stressor that affects health in young children and its relationship to asthma outcomes. And so what the study showed is that African Americans have the highest rates of asthma prevalence and mortality. Within this sample, 48.8% of the participants said they had experienced discrimination, And youth who had experienced discrimination had very poor asthma control. And those that had experienced discrimination also actually were more responsive to albuterol. And what this means is that albuterol is a medication that you're only really responsive to if you have significant asthma, particularly if your asthma is poorly controlled. And so the fact that these kids had poorly controlled asthma and were responsive to albuterol means that their asthma is poorly controlled because of their stress. So I just wanted to walk you through what inflammation in asthma actually looks like. And so on the top, you see this is a healthy airway. That's nice, big and pink and open. And then the one on the bottom where it says severe asthma, you can see that the lining of the lung itself is severely inflamed. There's a lot of mucus, and the muscles are squeezing each other super tight, which is why you get coughing and wheezing and have chest pain with asthma. You have all these white blood cells that help your body to fight different types of infections. But what we're learning is that when you are stressed, you have higher levels of these white blood cells that then cause symptomatology of asthma. So that kids with asthma, you can see the black circles. They have higher levels of these different types of cells that are related to stress that actually make asthma worse. So given all that, right, like it's really hard to talk to families about all of this trauma and adversity that's going on, right? Our real goal is how do we actually counterbalance on both a community and a biologic level? How do we counterbalance the adversity? And there's a quote that I like from Dr. Jack Shankoff at the Harvard Center for the Developing Child that says, in the final analysis, resiliency is rooted in both the physiology of adaptation and the experiences that we provide for children that either promote or limit its development. And I like this graphic of it's like a fulcrum. And how do we actually counterbalance these negative outcomes with positive outcomes for children? There are some ways that I've been thinking about how we can promote resilience, particularly around early intervention, right? And part of it is to bring the science to our communities, to educate and to guide parents about what stress can do on their bodies and on their child's bodies. We've been piloting these clinics called resiliency clinics, where we actually talk about the neuroscience, we talk about the biologic disruption that happens secondary to stress so that we can actually shift the dialogue from not what's wrong with my child, but what's happening to my child. What's happening to my child that's actually affecting their biology and then leading to these outcomes. We need to really focus on multidisciplinary approaches in order to talk more about the resiliency. We need to be able to link families to more resources and then advocate better for our patients and families. There is literature about buffers to stress, and the literature suggests that toxic stress is actually mitigated by having safe, stable, buffering relationships with caregivers. Those caregivers can provide resilience, social connection, knowledge about parenting and child development, concrete support. And we also are learning a lot more about the buffer of place and nature to help to prevent the negative health outcomes from toxic stress. Courtney and I are hoping that we can actually have one of our nature champions talk about the effects of nature on stress and how nature in and of itself can decrease the stress cascade, can help to improve blood pressure, and can help to promote a sense of well-being. One of the things that we started to do in my clinic is talk more about joy. So I helped to develop a technology platform called Find Connect, which helps to screen for these unmet basic needs such as food and housing, access to transportation, access to nature, etc. And we also ask about joy. And so we ask every single family, to the caregiver, can you share something great about your child? And then we ask all children who are over the age of 3, can you share with us something great about your mom, your dad, whoever is the caregiver that brought them to the visit today? We ask, would you like to share anything good about your home, neighborhood, or school, and to share what makes them happy? One of the really fascinating processes that I've been able to be involved in is the creation of this tool. We call it PEARLS, like I said. It stands for the Pediatric Early Adversity and Related Life Events Screen. And we've been working within our state in order to get this tool disseminated across the state. There was a legislation that was passed in California. It's called AB 340. That will mandate that every single Medicaid-eligible child in the state of California gets screened for trauma. And we are super excited that our tool is one of 3 tools that the state is going to recommend to be used statewide and to generate a billing diagnosis that the state will use for reimbursement to clinics that screen for ACEs. We also have a new governor, and our governor allocated $41 million in his budget to screen for ACEs and child development. And a lot of this is due to the work of my co-principal investigator, Nadine Burke-Harris, who is the first Surgeon General in the state. It's truly amazing to see how research and data collection have helped to drive policy in California. And I would love to work with those of you on the phone to see how we can drive the same type of policy changes within your states. So our North Star is that we want to be able to create a buffer to help to promote healthy environments that, despite significant adversity, allow all children to reach their most healthy trajectories. There's this quote from the Ohio Community Collective that says, working on social determinants of health /ACEs is both scary and reassuring. If we don't do this system level change, we will always be chasing the problem. Here's a list of some of the publications that I talked about. There are also citations throughout the presentation. And I would love for you guys to contact me, but to use the last 10 minutes to open this up for conversation.
All right. Well, thank you, Dana. So we'll go ahead and open up the floor for questions. So if you want to type any questions in the chat box. Dana, we did receive one earlier that was about the percentage of ACEs for Native Americans. It wasn't on the slide towards the beginning as far as that specific race broken out, but I didn't know if you knew anything about kind of where Native Americans stand.
In terms of the breakdown by race, I don't know, and that wasn't part of the national data set. But the data on ACEs, it's still growing, and I absolutely think that that's a really important deficiency, and that we should do the research to find out.
Right. Thank you. Okay, I'm not seeing any other questions at this point. We did have a comment, though. Actually, a question just came in. Are community action agencies involved in building resiliency to at-risk communities? That's probably a question more for us as the Community Action Partnership. But I mean, what I would say as far as my answer to that is, absolutely, I think that a lot of community action agencies do different approaches in working in their communities to try to help build some of that resiliency. I can't think of a specific example off the top of my head, but that would be interesting to, look further into to see about initiatives that might be working to do that. All right, we're having a few more questions come in. So one of them is, how have you used educational tools to teach your community?
Mm-hmm. So that's a great question. So several things. So for our families that are part of the work on developing the PEARLS tool, every single provider received what we call anticipatory guidance sheets. And so anticipatory guidance is what we do as providers when we talk about healthy eating, about sleep. And so we developed anticipatory guidance around ACEs and stress, as well as about resiliency. And so when families are getting screened, the provider will talk about how it's really important to talk about the things that are going on in an individual's life, in our communities, because we know that these factors can actually lead to poor health outcomes. And our goal is to create an environment where everyone is healthy as possible. And so we do a ton of education with our families through anticipatory guidance with the providers. We also, as I said, have these resiliency clinics, and the entire curriculum is around education, around mindfulness, self-regulation, co-regulation, toxic stress, the brain science, and then around curriculum topics such as nutrition or sleep or exercise.
And kind of a follow-up or more specific part to that question is, how do you work to break down medical terms to a low level of health literacy?
So we actually did quite a bit of design work around that topic, and what we found is that families, they want to know the science, and they want to know the science in details because every single parent loves and cares for their child. We found that parents get it, and it's actually this really incredible moment that happens when we ask a caregiver to take the ACEs questionnaire for themselves, and then they take it for their child if the child is less than the age of 12. And there's a moment when they're looking at their score and they're looking at their child's score, and what they see is that the scores are really similar. And then there's this aha moment when they understand, right? They understand the intergenerational trauma and how it's impacted them and how it could potentially impact their child if it's not already. And parents want the science. They want the education. They want us to do more of it, is what we found. And so I haven't found that we need to dumb it down or reduce the literacy level for families. Families get it. When you talk about how stress is impacting the brain and impacting the body, how stress causes the release of different types of hormones and cells that lead to inflammation that then cause their kids' asthma to be poor, families get it.
All right, thank you. Another question that came in, can you talk a little bit more about immediate strategies that agencies can engage to interrupt the impact of stress and trauma on children, particularly from the racial equity perspective?
Mm-hmm. It's a great question. And I do think that often we have to just start, right? Start talking about it to everyone. Start screening everyone. Start acknowledging that this stress and trauma, whether it's from discrimination or food insecurity or homelessness, is actually affecting our minds and affecting our bodies. Start generating data, and it's a fascinating example about what happened in California, how we started asking, we did a research study on it, we collected the data, and now it's statewide policy, right? We have to start asking the questions. We need to have data systems that allow us to tell stories, and then we need to do advocacy.
All right, and then another one is, in your view, what are the key health and well-being indicators that agencies can incorporate into their community action plans? So maybe which do you see as very attainable or kind of a simple start for agencies who want to start the health intersection journey?
Yeah, that's a great question. And in order to answer it most accurately, I think that it needs to be within the scope of what your agency is already doing. Some of the indices that we want to start looking at, And I understand that my perspective is that of a healthcare provider, and so I can look at utilization data or I can track health outcome data. But data that's equally as important is parent or patient reported data. And so there's a lot of validated tools where it can be patient reported. So tell me about your health. And actually that data is almost as accurate as going into a health record. You can also track data about school readiness. And then there's a lot of data that's already collected by cities and states about child maltreatment or about graduation rates. And so it depends upon what matrices your organization is already collecting and to see if you could add one about missed attendance from schools or what percent of your kindergartners are actually ready to learn, or asking patient-reported health outcome data.
Okay, thank you. We also had one about what advice would you offer caregivers or frontline staff for their own self-care?
Yeah, that's a good question. I do want to go back, Courtney, if I can, to the last question, is that this ACEs screening tool, it doesn't belong just to healthcare, right? Community organizations can start asking about food insecurity and referring to food banks as well, right? Like we can start to actually ask about experiences of discrimination and start calculating that data for our communities nationwide. And that's really, really powerful. And so none of these tools simply belong to the healthcare sector, and I actually think it would be an amazing thing if when families walk through the door of a child care center or a library, they were also asked about their food insecurity or housing instability, whether or not they feel safe in their communities or they're experiencing domestic violence.
Okay, and where can agencies access the ACEs questionnaire or assessment tools?
So the citation is on the slides, but you also can go to the Center for Youth Wellness website, and the questionnaire will be posted there.
Okay, great. And then coming back to that question about self-care, so what advice would you offer caregivers or frontline staff for their own self-care?
So that's a really fantastic question. I don't underestimate how hard it is to start to universally ask these questions because staff is impacted just as much as our patients are. And there's a ton of vicarious trauma, and it can be really triggering for staff. I think that we all have been trying to move towards having a trauma-informed system that supports staff and helps to promote equity. The trauma-informed work is huge, and it's built upon these ideas of cultural humility. I think that the Community Action Partnership has been doing some webinars about trauma-informed care and what it means to create a healing system. But that's essential. I mean, you can't act, in my mind, like that's the place that we have to actually become more trauma-informed before we can start doing screening, because then we're just going to re-traumatize our staff.
Great, yeah. We are going to be doing some webinars coming up in the spring on trauma-informed care, as well as getting an on-demand e-course out there on the topic as well. We've had learning community groups that have focused on that in the past, and I think it's very important and definitely relates to this topic as well. All right, I think we have one last question before we wrap up the webinar. So this is actually coming from the Community Action Partnership, but we recently learned that you are an AmeriCorps Vista alumni. So how has this immersion in anti-poverty work informed your health and well-being policy perspective?
So I was in AmeriCorps, and I was actually part of President Clinton's first class of AmeriCorps Vistas. And it's really fascinating how you go through this journey, and sometimes you end up just where you started, and that's actually a good thing. So when I was in AmeriCorps, I worked in the LA Free Clinic, and I was a peer health educator. I had just graduated from college. I was 2021, and I was working with other youth that were homeless or in substance abuse recovery programs or part of gangs in the area. And we all traveled together. We went to homeless shelters and squats and juvenile justice centers. Sometimes at night we would all go to clubs together as part of work, and we'd pass out condoms. And we would just talk to other young people about HIV and AIDS, substance abuse, community violence, how to keep themselves safe. And it's totally amazing how now, 30 years later, I'm actually still doing the same work, just kind of on a different level. And being able to actually sit with my peers and actually be there in relationship with other young people who were really going through a lot, it really taught me a lot about strength and resiliency and acceptance and the ability to connect and the need for the work that we're doing now.
Good. And I think one final thing related to that is, what advice would you give agencies who want to contribute to policy conversations either locally, regionally, or nationally?
What advice would I give to organizations that want to do policy work? Is that the question, Courtney?
Yeah, there's agencies that are looking to get involved in policy conversations, and they want to be able to contribute to that, whether it be at the local level in their community, whether it be at the state level. You talked about some of the things happening in California. Yep. So just what advice would you give people who want to contribute but maybe don't know where to start?
Absolutely. And so for the state work groups that I sat on, those actually all were public meetings. And there was always a time during the state work group meetings when the public could comment. And the same is true on a local level. Oftentimes, the mayor or councilman will have town halls. You can write letters. I recently, we reached out to our Congresswoman Barbara Lee, who is exceptional, and she now is the first African-American congressperson to be chair of the Appropriations Committee. We wanted to share with her the data on ACEs and determinants of health in her district. We contacted her staff. We wrote her a memo, and she was really appreciative. And so some of it is just reach out to your congresspeople. Let them know what's happening in your community. You can always sort of write blogs or write articles, but I think the biggest thing is just showing up at those town halls, at those policy meetings, reaching out to your congresspeople.
All right. Well, thank you. I think that concludes our questions for today. We really appreciate. We had some really great questions. So good conversation to wrap up the webinar. Thank you very much, Dana, for your time today and sharing your expertise with us. We really appreciate it. I'm going to go through these last few slides that we have just to let people know some of our webinars that are coming up on Wednesdays. We have our webinar Wednesdays every Wednesday at 2 p.m. Eastern Time. In some of the coming Wednesdays, we're going to be talking about career pathways as a leadership development framework and community action. The Massachusetts State Association is going to be talking about some research that they've been doing on leadership development. Also on March 6th, we're going to be talking with a state association as well as a local community action agency about their leadership transition and how to sustain the organization during those times. So all of those can be registered through our webinars page on our website. Our resource library is also up. This is where we put the webinar recordings as well as the slides after each webinar. So within a couple of business days, you can expect the recording from today as well as the PDF of the slides to be available online. At our resource library, we also have lots of previous webinars that relate to this topic as well. So you can actually go to our resource library and there's a menu of checkboxes, and one of them is health intersections, and that should bring up related webinars to this topic. And then lastly, we do have our CSBG TNTA Resource Center that has hundreds of resources available to the network, publications that have been done, training curriculums, webinars. So always feel free to check out those resources. And as we close, we'll leave you with our contact information here at the Learning Community Resource Center. So feel free to reach out to us as needed anytime you have questions or comments, or just let us know what you're doing in your community, especially with what we talked about today. Always interested to hear what's going on at the local agency level to address the social determinants of health. So thank you all for joining today. We appreciate it, and we'll hopefully see you next Wednesday.